introduction, Mitra. Like Mitra said, I'm one of the peds infectious disease physicians at WVU. I see Dr. Moffat's on here too. So we've had a pretty significant increase in the number of cases we've been seeing. So we were hoping to share some of the presentations and how we have managed these children so far. When I was looking for the mute button, I was also trying to do a head count of how many kids we've had so far, and I think there was 7 at in Morgantown. Um, we can go to the next slide, Mitra. I have nothing to disclose. Next slide, please. Few learning objectives for this talk. At the end of the session, participants will be able to identify clinical features of MISC, diagnose and manage MISC, formulate a follow-up plan to coordinate different subspecialists that need to follow these children. Next slide, please. So this was probably our, my gosh, I have to like look at their faces to remember which number was this. This was our third or second case. He presented, he's a 7-year-old male, presents with chief complaint of fevers and fatigue for 7 days. Fevers were every day, Tmax was 104. He was complaining of being tired, decreased appetite, complaints of everything hurting, his belly hurting. 2 days prior to admission, mom started noticing his eyes were red and like the eyelids were swollen and red. He was seen by a pediatrician and prescribed antibiotics and steroids 2 days after this fever started, but nothing had changed. He was still having high fevers and everything. Next slide, please. Significantly, mother had tested positive for SARS-CoV-2 about 4 weeks prior to presentation. No other family members were sick. No other family members had tested positive. The father had been tested, but no other kids had been tested. Pete's team, when I was consulted, noticed this macular rash all over the body, which was pretty apparent for that team. But the next day when I went to see him, it wasn't there. So next slide, please. So he was lying in bed, really uncomfortable, really dry, cracked lips, slight conjunctival injection, but a lot of puffiness around his eyelids. He was tachycardic. He was febrile at that time. He did not have rashes, any kind of rashes when I went to see him. All right, next slide, please. So these were his labs. This was already done by the PEDS team. So whenever we see kids with prolonged fevers, we always think about Kawasaki. So this was their workup for Kawasaki. CRP was elevated at 44.9. Our normal is less than 9 or less than 8. White cell count, total white cell count was 8.1 with a neutrophilic predominance 81%. Hemoglobin was on the lower side 10.4. Platelets were fine 262. UA was negative for WBC, so we always look for pyuria in our for our rule out Kawasaki. We checked the liver functions, ALT, AST were normal. CME and EBV serology were done because we were trying to find a cause for these fevers, and they were both just positive for IgG, indicating a past infection. We can go to the next slide. So we did some additional labs. First, we did the SARS-CoV-2 IgG, which was positive. And then once you have that, we started looking at other things that could be affected. So we did a D-dimer, which was super high, and then BNP, which was 221. Our normal is less than equal to 100. From all the reports that we had heard, there was significant cardiac involvement. So we got an echocardiogram for this kiddo. Everything was normal, no evidence of myocarditis or any strain on the heart. We can go to the next slide. So he got IVIG steroids, low dose aspirin. He has been the first kiddo that we saw as a follow up, and his repeat echo is negative for coronary artery aneurysm or any abnormalities on his echo. I have another case, so I snuck in a second one. We can move to the next slide because this kid's presentation was pretty different from what we had seen. So this is a 14-year-old boy who was admitted with abdominal pain. He was actually admitted to the peds surgical service for rule out appendicitis. He had abdominal pain on the right side, lower right side, about 7 to 8 out of 10. Nausea, vomiting, diarrhea, fever started after the abdominal pain. Um, and he was complaining of a headache, and like the other kid, everything was hurting. We can go to the next slide. So for this family, father had tested positive about 6 months ago. Um, all the other 3 household members also had tested positive. All had significant loss of taste and smell. Our patient had diarrhea but no fever. Like he said, I got over that illness really quickly. So that was interesting too. But he clearly remembered like losing the taste and smell. We can go to the next slide. He was tachycardic, but he was afebrile. There was significant right lower quadrant and left lower quadrant tenderness. Besides that, he did not have a rash. His eyelids looked a little puffy, but not a whole lot. So we did more labs on him to see what other systems were involved. We can go to the next slide, Mithra. His CRP was elevated at 73.9. 11.3 white cell count with, again, neutrophilic predominance and a lower lymphocyte count. Hemoglobin and platelets were fine. Platelets were on the lower side. His prothrombin time was slightly elevated. LFTs were normal. UA was negative. Blood and urine culture negative. And surgery kept calling us like CT and ultrasound have been negative for appendicitis. So this is something else. We can go to the next slide. Significantly, his D dimer was elevated. His BNP was normal, and his IgG for SARS-CoV-2 was positive. His echocardiogram was also funny. There was no myocarditis, really. Everything else was normal. But this was a note that was made by the cardiologist. The apical wall was hypokinetic. Other segments showed normal contractility. And this was the first time I read an echo with this term diminished strain, which is a global longitudinal strain, which was 13.9%, and normal is somewhere minus 22%, which doesn't make sense to me. But from what I've understood from cardiology, this is a way better marker than ejection fraction to show the normal contractility. So more negative is better, which sounds really doesn't make sense to me, but it does. His coronaries were normal. There was no pericardial effusion. We can go to the next slide. So I wanted to pause and see if there were any questions about these clinical presentations before I do the quick overview and review of MISC.
Dr. Gupta, we don't have any questions in the chat as of now, but I do encourage anyone with questions to unmute and feel free to ask away.
All right, we'll move on with the quick overview. Significantly, this week we have had a child who has come in with, again, this abdominal pain presentation, and he has hepatitis with slight elevation in his liver enzyme. So I'm thinking that we have seen the whole spectrum. We can go to the next slide, Mithra. So when did we all first started hearing about this? This was in May when UK first made this report in the Lancet. It was an online correspondence that was published. They talked about, they had from mid-April, they had noticed that there was a cluster of about 8 children Yes, 8 children with hyperinflammatory shock, features similar to atypical Kawasaki. And the baseline number was 1 or 2 children per week. So that was a significant increase. So over 10 days, they had seen 8 kids. Similar reports were published from from Italy as well as from France. From Italy, I highlighted that in the past month they found a 30-fold increase incidence of Kawasaki-like disease. So that was pretty significant, and this led to um, the initial article from UK led to the Health Advisory Network Health Advisory release as well. We can go to the next slide. So this was part of the health advisory news that was released by CDC as a case definition for MISC. These were different from the UK and the WHO, so I just wanted to focus on this one. Age less than 21 with fever, lab evidence of inflammation, and evidence of clinically severe illness requiring hospitalization with greater than equal to 2 organ involvement. And you can see the list, no other diagnosis, and then you should kind of have a temporal association with like either the child is positive by PCR, serology, or antigen test, or was exposed to COVID 4 weeks prior to onset of symptoms. Um, so we struggled with the labs were are listed there. The other additional comment that they had made was some children may fulfill or full or partial criteria for Kawasaki. So for the younger kids, we call them Kawasaki or MISC, but overall the management was the same. We can go to the next slide. So a little review on what we have seen so far from the publications. This was an article in NEJM published end of June. They reported all of the cases that met criteria between March and May in New York State. More male predominant, and then there was the age distribution is there, and you can see there were more kids in the 6 to 12 age group. Mithra, press the enter button. I think I have animations in this on this slide. Yes, okay. So you can see the GI symptoms were high on both groups, but in the 0 to 5, you can see there were less of dermatologic, more of dermatologic or mucocutaneous in the 0 to 5. Myocarditis was a pretty significant percentage of presenting symptom or what they discovered during these the hospitalization. The neurologic, I would think, like the older kids can tell us better about headaches because all of our kids have reported headaches, but they've all been older. So there is definitely interesting and varied presentation for these kids. We can go to the next slide. There are more animations in this one. So, so this was presentation, the symptoms at presentation. The most common feature was about 100% of the kids had prolonged fevers. About 80% had GI symptoms. And then more, Mithra, keep pressing the enter button, I guess. Yes, there we go. Another one. Okay, and there should be one more on this page. ICU admissions were about 80%, and I get that. It seems like a lot that 80% of these kids were admitted in the ICU, but early on, when we started seeing these kids too, we were like, this kid needs to be in the ICU. But there, after we have learned more and we're more comfortable in identifying these kids sooner, we're able to manage these kids on the floor. We can go to the next animation. And about 61% needed vasopressor support. And you can see the coronary artery aneurysm is not a whole lot in this group. We can go to the next slide. Ooh, and there were 2 deaths in New York at that time. We can go. This was an interesting graph, and I have it from the US data too. So the blue ones are your surge in your daily average of your COVID-19. And then you can see after the peak, 4 weeks after the peak is when we started seeing the reports for MISC. So there is, it definitely seems like not an infectious, but more of an inflammatory process. So there is a temporal association, and that's what this graph shows. And this is what we have experienced too here in West Virginia. After the holiday surge, we started seeing more cases of MISC. We can go to the next slide. The same month, a summary was published for MISC in US children and adolescents. The two major sites that were reporting were New York and Michigan, where the initial surges were. And then again, this is the temporal relationship on the right side, showing the spike in COVID-19 first, and then your MISC cases go up slowly. So we can go to the next slide. So I want you guys to just focus on just the all patients column. I think there's an animation to highlight the whole side. Yep. So they broke the group into lab confirmations versus an epidemiologic link, but I just want you guys to see the all patients number. So there were more males, 62%, which was similar from what New York had reported. And then the age group distribution, if you look at the 1 to 4, 5 to 9, and 10 to 14, they were about a quarter person for each, less than your 1-year-old kids, so not that significant. And then looking at the race distribution, you can see that there were more numbers of Black non-Hispanic or Hispanic or Latino percentages and these were the ethnic groups that had more surge in cases too and were getting more affected. So there was a significant racial difference in these two groups. All right, we can go to the next slide. Oh dear, there are more animations up here. Got it. All right. This was the way they described their presentations. So GI involvement was the most, 92%. But looking at hepatitis, which our new patient has, it's not that common. Hematologic involvement, DVT, P, 76%, mucocutaneous 74%, respiratory 70%. So pretty consistent reports, similar to what New York had reported. We can go to the next slide. This was for cardiovascular involvement. About 80% of the kids had cardiovascular involvement. None of the ejection fractions were so, at that time they were using the term ejection fraction. This is global longitudinal strain is a new terminology that has come into play. So that's how it was reported there. And then you can see the coronary artery dilation was not a whole lot. And then about 48% of the children needed vasopressor support. We can go to the next slide. Just arrows to highlight the things. Yes, one more. Yep, okay, perfect. There are lots of arrows in this one, I remember, because I matched them. So you can click them out right now. So lymphocytopenia, I think, okay, just two. Lymphocytopenia was really a predominant lab finding for the children, as well as CRP, which we had seen earlier. So that's where the initial lab evaluation would start, is getting a CRP and a CBC with diff. All right, we can go to the next slide. So I was gonna pause and see if there were any questions here. No? No, okay. All right, we can move on then. So the only published guidance document is from American College of Rheumatology, and they talk about both MISC as well as hyperinflammation in a pediatric COVID-19 patient. This is version 1, so it's a living document. Every time I've looked at it, like I looked at the preprint, and it was completely different from what was actually in press. So they just had a panel of multidisciplinary task force, rheumatologists, peds cardiologists, peds infectious disease, and pediatric critical care physician group to address the management. We can go to the next slide. So what we did was we created our own clinical pathway. This was a work in progress. We just, and I promise, this is just a screenshot of both the sites, but we'll break it down. So we first just made the clinical presentation part, and then now as we have learned more about treatment, my pharmacy resident has been helpful in helping create the second part of this clinical care pathway. So we can go to the next slide. So this was the top part of it, just listing your clinical and historical features. So rash can be polymorphic maculopapular or petechial. GI symptoms, from our cases, we have also learned the diarrhea, abdominal pain, and vomiting. Some of the kids are presenting with like swelling of hands and feet and redness of hands and feet. Oral mucosal changes, red lips, cracking of lips, conjunctivitis bilateral without exudate, so it's pretty similar to Kawasaki. And then some kids have had lymphadenopathy. Neurological symptoms include headache, irritability, lethargy, and altered mental status. And then, everyone's very forthcoming about the epidemiological link to COVID. If somebody has tested positive and they were quarantining together. We can go to the next slide. So this is part of the initial evaluation. Once you have those clinical criteria, so it just splits into MISC, possible MISC with suspected MIC with shock, which we have been managing in the intensive care unit. So these children have evidence of myocardial dysfunction or hypotension or vasopressor requirement. Common features between these two groups is they have had fever for greater than equal to 3 days. For the shocky ones, it's greater than equal to 1 day, and then greater than equal to 2 clinical historical features. The document that I had shared from rheumatology talked about the tiered lab approach, and that's what we incorporated in our clinical pathway. So getting your basic markers of inflammation along with LFTs and a blood culture in a febrile kid, that was our basic lab testing. For the kiddos with the shock, they get an ICU admission and they get pressor support and more fluids. We can go to the next slide. For labs, CRP greater than equal to 30 milligram per liter. It depends on every site. This was also adopted from the CHOP pathway, and they had it greater than equal to 3, so their normal was anything less than 3 or less than 2.9. ESR greater than equal to 40, lymphopenia. So after those reports were published, we started seeing that lymphopenia was a characteristic feature. So less than 1,000, thrombocytopenia or sodium less than 135. So admit for further evaluation. If these lab criteria are not met and your exam is reassuring in the clinic or in the outpatient office, there is, it's reasonable to discharge these children, but with close follow-up, like re-examining them the next day. The other thing that was really emphasized was sometimes the children don't present with all the features. So you might get bits and pieces in the history, like the eyelid was swollen 1 day and then the feet were swollen. So it has to be, and just because it's not present on the examination doesn't rule out that those features, that they don't qualify for those symptoms. After you have, so the second tier of exam of the labs is COVID PCR, COVID immunoglobulin, COVID antibodies. We have been getting a respiratory panel, troponin, BNP, D-dimer, ferritin. All of these kids have gotten an EKG, echo, and a blood culture. Peds infectious diseases has been involved early on, and so is cardiology. Especially for the older kids, because we've seen that higher number of myocarditis cases in the older kids. We can go to the next slide. Treatment, this is hot off the press for you guys. It was published online in on Feb 1st. So this was published from, Italy or France, I cannot remember now. But they looked at that group. It was a retrospective review of their cohorts. One group got IVIG, one group got IVIG and steroids. There were 5 children who did not receive any treatment or just either of these treatment. It was a small group, but 3 out of 34 children. So there were total 34 children, and 9% in the IVIG plus steroid group and 51% in the IVIG alone group did not respond to treatment. So what their p-value was significant was that IVIG and methylpred was versus IVIG alone was associated with lower risk of treatment failure. The rest of them were associations because the p-value was not significant. But they found that IVIG and methylpred, so steroids, versus IVIG significantly associated with lower risk of having to use a second line of treatment, need for more hemodynamic support, acute left ventricular dysfunction function after initial therapy, and even they saw that the PICU stay was shorter for the IVIG plus steroid groups from 4 to 6 days. We can go to the next slide. This is the second protocol that was published in the Journal of Pediatric Critical Care Medicine. It's still an online article. It's not been published, but this was from New York, where they divided the groups into mild, moderate, severe. And you can see like the doses vary for the steroid a whole lot for these groups, and then the steroid taper also varies. So our group tried to simplify this approach, and that's part of the second page of our clinical pathway. We can go to the next slide. So IVIG stays the same, 2 grams per kilo over 12 hours. It's a flat rate. If there is concern for left ventricular dysfunction or hypotension, some people do split it into for over 2 days. So you do 1 gram one day, and then you do the 1 gram the other day. Also, we recommend consulting with cardiologists if you are worried about cardiac anomalies. We can go to the next slide. And this is what we came up with for steroids. And this is what we have done with most of the children, and it has worked out pretty well. So something that was really different, and initially I was really confused because if you look at the recovery trial for respiratory distress in COVID patients, that uses dexamethasone. But for this, for MISE, we should be using methylprednisolone or prednisone or oral prednisolone. So the initial dose is 2 mg per kilo per day divided twice a day for 5 days, and then you taper it to 1 mg per kilo per day divided BID and then 1 mg per kilo per day daily. So in 15 days, the taper is done. Before those 15 days are over, we usually end up seeing these kids in our clinic, so we can get a good assessment of how things are going. Our immunologist, like we saw in the New York protocol, there is a tiered approach. So some people do choose to use consider pulse dose methylpred for really sick kids who are on vasopressors. But then we want the taper to be simplified too. So you do the pulse dose steroids, 3 mg per kilo daily for 3 days, and then you taper them over the next 15 days. Addition of GI prophylaxis with either famotidine is recommended. We can go to the next slide. So we have had one child who had refractory treatment out of this group or out of this cohort, who even before his steroid taper was done started having fevers and like trouble breathing, and he developed coronary artery dilation. So that's when we started looking at like what other places are doing and what is the evidence. So again, the evidence is a lot of published. There's not a lot of publications on this. So we reviewed on our ID listserv, and there is again involvement of the immunologist, and most places are doing anakinra. 4 to 10 mg per kilo per day, but this is all with the immunologist involved, and then, or you can go to intensification of the steroid regimen and then taper it out. So these were our modulation therapies. We can go to the next slide. So a little bit about aspirin. For age less than 12, most of the places are just doing a low dose aspirin. So in Kawasaki, we usually did high dose aspirin for the first 48 hours or till they became afebrile. But low dose aspirin seems to be working fine. But if you notice any other VT risk factors in your age greater than 12 years, medium risk, high risk, then there is consideration to use enoxaparin with a goal. This is way more than infectious diseases. So we had the hematologist look this over and they were like, this is fine. So we're gonna stay with this. Yeah, next slide, please. So I would be amiss if I don't mention COVID in kids over the overall picture of what is going on. We can go to the next slide. So AP has been publishing AP in with Children's Hospital Association has been printing this weekly or every 2 weeks report, which is really nice. You can look at this at leisure. But overall, summary is children are represent 12.8% of all cases. Over the past 2 weeks, again, there was a 12% increase, and there's a really nice graph to show that. About 1.2 to 3% of the hospitalizations were for children, and about 0.1 to 2.5 of all child COVID-19 cases resulted in hospitalization. Mortality is reported somewhere between 0 to 0.2%. Next slide, please. So you can see how the numbers have gone up after Halloween and during Thanksgiving and Christmas, and we're still seeing a plateauing of the numbers of infections in kiddos. Next slide, please. So in summary, all the COVID, rare complication of COVID-19, the MISC, we should continue to have a high index of suspicion for MISC. It's a diagnosis of exclusion, and all infectious as well as non-infectious differentials like malignancy, leukemia, all of those should be considered while thinking about this. Management is usually in the hospital. It's multidisciplinary with intensivist hospitals serving as the primary care givers in consultation with subspecialists. There is most of the places are having these kids come back in 2 weeks to do an echocardiogram and EKG. We have infectious disease. We have also been seeing these kids when they come back, especially if their labs were abnormal. We want to make sure that the CRP and ESR and all of the labs are trending down, and just to be there to help talk to the families and see the outcome. Next slide, please. So I wanted to thank you all for your time and attention. I did not have financial disclosures, but I do have to disclose that I have a serology study going on in which we are testing household members of positive people or even close contacts of positive people with antibody testing. When after seeing all these kids, whenever we go talk to the families, they're like, we were told that probably the kid is positive, and we all just quarantined together. By 10 days, the antibodies should form, so we can test them free of charge through a study to also see what the transmission dynamics are. The other thing that a lot of families have mentioned and was brought up was are we doing it wrong by just assuming that all of us are positive and just living together and keep exposing each other? So what I tell the families is, if you know somebody is positive, they should wear a mask in the house, try and stay away. But if you have somebody who tests positive and they have household family members, once they're done with their quarantine isolation, send them my way. I will be happy to test the families and look at the antibodies to see if the other kids had and were exposed and had an infection. So far, we have this people that we have enrolled. We've had 2 people who were positive in the household member group who were not identified as being positive. So something to watch for. For guidance, I just tell the families all these questions about, I just tell them to keep an eye on for these features, fevers, high fevers and rashes and any eyelid swelling or GI symptoms, nausea, vomiting, diarrhea. All the families are always like, we thought this was a stomach flu, stomach bug. So pretty classic presentation. I see a question about return to play activity in sports physical. So the post-COVID, that is, I don't remember or I did not review that, but for post-MISC for 2 weeks till they see the cardiologist again, they are not, no exertional activities, limitation of all activities. I saw one of the kiddos yesterday whose echocardiogram early on was normal, and then we repeated it at 2 weeks, and she has, again, that hypokinetic global longitudinal strain score. Her score is lower or more away from the negative. So she has been put on, like, she's not allowed to do any exertional activity for 3 months till she gets a repeat echo. So there is pretty significant, and we are learning more and more about this as we are seeing our cases.
Thank you so much, Dr. Gupta. We truly appreciate you presenting the case today and going in depth with MISC and everything. I know we have been getting several questions in the chat, so we can jump right into the Q&A session. And you've been doing an awesome job, monitoring the chat and everything too. So I appreciate that. Dr. Hodder and Dr. Costello, I know you both also hopped on here, so please feel free to jump in anytime with helping to answer any questions and everything. So we can just jump right into some of the questions coming in through the chat. The other one that we got in was asking, does anyone have any speculation as to why the syndrome is not seen in adults? Also, has anyone seen coronary aneurysms that have been associated with Kawasaki's disease?
So from what I have seen, and this is more of like with the adult patients being admitted to the pediatric intensive care unit, is there has been one case amongst an adult who presented with symptoms. He had hyperbiliary and he met all the criteria for MISC, and there is a report. There are reports from Europe about adult it's called like in PMIS or pediatric, I don't know how they called it, but it is associated. There are reports of adults. We don't know why adults are not more affected. The coronary artery aneurysm, so the one kid that was refractory who came back, he was also really young. He was 3. So Dr. Moffat, Dr. Weiss, we all went over like, could this have been Kawasaki? Sure, but there's no way we could differentiate if this was Kawasaki or MISC. So we just called it Kawasaki/MISC. So he had coronary artery aneurysm at the 2-week mark, but he's doing better now.
Great, thank you so much. And thank you, Dr. Moffat and Dee. I know you also chatted in that resource. So any resources coming in, I'll be sure to include in the recap email for everyone to have. The other question we got in was asking, do you know convalescent plasma and or monoclonal antibody used in MISC with effective outcomes?
So we have not had to use that. And I think we have been able to get away with IVIG and the pooled antibodies and just immunosuppressing with the steroid. So we have not used it. And I have not seen in any of the pathways that were distributed on the listserv or any other places that have published any thing more about the convalescent plasma or the antibody therapy.
Thank you very much. The next one we got was saying brain fog is something that has been described in adults for months post COVID-19. Have you experienced this in children with MIS-C?
I have not, but I also see them briefly in the hospital and they're after 2 weeks later. There was one kid who was admitted with fatigue. And he was so fatigued and tired that he fell asleep while getting a haircut in a shop. So that was a really funny presentation of the tiredness that people experience. So yeah, I have not seen. If any of the pediatricians are noticing anything, please chime in.
Absolutely, thank you. And Dr. Costello also chatted in if you could speak to clusters with MIS-C and if there have been any reports on that happening in communities.
Yes, Dr. Gupta, I'll give you a little bit more. So there's been reports in the southern part of the state that there was like one county where there were like multiple cases of MIS-C, and it just seemed to be like peculiar, like, is it a particular viral strain or whatever, or predisposition, but it just seemed like, we hadn't had cases for a while, and then there were just a bunch more cases that kind of came all of a sudden. So I don't know if other places have noticed that, but that was kind of the background for my question. And thanks for doing this on, you did a great job even on very short notice. So thanks, Dr. Gupta.
I have not been following besides the numbers that we have seen here, are there other hospitals that have reported admissions?
Yeah, in Charleston area, there's been, that was where the first,
right,
cases that we've seen. And so I just got contacted by a colleague in Charleston who's asking, and I told him he wasn't able to attend. I was like, oh, tomorrow's echo is on MIS-C. And so it was just a question of, is this something that we're seeing more of, and it was just, I think there was just like one county or area where there were multiple cases in like one county. I think Dr. Holstein's on the call. She's in Charleston, sorry. But I think we just saw a bunch in one area, and it brought us to talk about, is that happening for a reason, or is it just completely coincidental,
Or is it because the amount of circulating virus in those counties is higher? Because we've seen like the first places to report MIS-C cases are Michigan and New York, which had the highest surge early on, and then few cases in California. So I would think it is related to the higher circulating viral numbers and having more cases and then getting more exposed. But that would be something to look at too.
I think there is the question, is there something genetic predisposition? Just like we know with Kawasaki's, it's more common in Asian and Black race than white. It's just that we have a lot of whites who also live in the United States, so white people do get Kawasaki. So I think that's interesting, whether it's also the surge of the local cases or not.
Yeah, I think that's an excellent point. And that was also one of the things to like look at, doing a deeper dive into these cases where we saw that. Because I also thought about the increased viral load. It made sense, or in some of the early cases we had, that was, the individual who got it, like every member of the family had it. And then the child later developed MIS-C. So, was the just viral load higher in that household? So, yeah, I think that those are all excellent points that I guess we'll just, as we've learned in this pandemic, continue to learn more as time goes on.
Absolutely. Thank you all so much. Dr. Weiss, I noticed you unmuted. Was there a comment you wanted to make as well?
I will make it. I had decided maybe I wouldn't make it, but since you caught me, I'll make it after all. So I have a colleague who's PEDS ID out in Tacoma, Washington. And so I had contacted her a number of months ago when the MISC first came out. And she said, well, you know, we really hadn't seen much coronavirus admissions in a children's hospital. And they have a children's hospital around the same size as ours. And she said, but, you know, gosh, we're admitting or evaluating for MISC about 4 per week. And which I thought was unusual for a hospital about the same size as ours. And so one of the thoughts I had was that there's some kind of a diagnostic bias, either by people in the community or whatever, you know. So if they're splashed on the headlines, you know, MISC attacking kids in Tacoma, and then and here are the symptoms, and then there's going to be people with those symptoms who come in to be evaluated, and because there is really no test, right? There has to have been coronavirus in the community or in the household, but you don't have to have a positive test. Then you're going to confirm cases of MISC that maybe weren't, and so I just think it's really interesting. And like Dr. Costello said, you know, the more this gets studied, we're going to maybe find out that there are people who are at higher risk, you know, sort of like what Dr. Moffitt said, but certain people are more prone to Kawasaki's, others more to rheumatic fever, others more to this or to that, and it'll be interesting. Thank you for noticing. I unmuted myself, though. I just appreciate that.
Absolutely. I'm notorious of noticing things like that. Thank you so much for sharing that, Dr. Weiss.
So there was a question about how do you differentiate these and what do you do? So it's well, you know, a sick kid with fever for more than 2 or 3 days usually should be evaluated. And we don't, with this, we don't wait for 5 days. I mean, Kawasaki's, it's usually 5 days, but I think that the thing that distinguishes these kids is they're sick. And so they're likely going to be sent to a children's hospital and be admitted. I think they need subspecialist care to evaluate. But what other things could there be? Well, we see a lot of FUO where we don't figure it out. But I think the fact that there's some very unique things that are present, and maybe we're overdiagnosing it, like Marty said, because we're thinking of it and we treat it. So I think I'm being kind of vague in saying, well, what else could it be? Well, we've had 2 kids now who've gone to the surgeon because of the worry about appendicitis, but they were astute to say, actually, maybe PEDS ID needs to see them. So anyway, that's how we would, you know, we evaluate these kids. It takes a village to make a diagnosis.
Thank you so much for sharing that, everyone. We have another question in asking if there are any post-COVID neurological and psychiatric disorders with MISC.
I think there'll be more to follow on this. We don't know, and like I said, we see them briefly. But if you guys are noticing anything, please let us know, or you know, start reporting all of this, because we don't know yet. But we have seen like kids are bouncing way quicker from this. So yeah, more to follow on this.
Absolutely. Thank you so much. And we got some questions in that are a little more general to COVID-19, not specifically for, oh, I see Dr. Costello, you chatted in a question. I'll let you ask that so we can stick to the didactic topic.
Sorry, there's one. It was kind of related, but not really. It was just a question someone sent to me with a large cohorts of people in certain areas with like familial coagulopathies, protein C, protein S, factor 5, and are those families more at risk to, I don't know if my much smarter IB colleagues have any comment on that.
I defer that to Dr. Weiss and Dr. Moffat.
I think it's what Shipra said, is that so far it hasn't been noted, but it might come out in the, we're part of several registries of all COVID in children. We're part of a PICU COVID, and then we're reporting all the MISC to the CDC. And some of you who are pretty astute have maybe seen on the news, I know on NBC News last week, they had a map of the United States, and the only place that had no cases was West Virginia. Well, that data has lagged because we've reported them. They just was not in that CDC report. So I think those are all things that actually may come out later. When you get enough numbers, then there is a trend or an association picked up. So I think, hold on.
Thank you so much, Dr. Moffat. We have about 3 to 4 minutes left, so I thought we could squeeze in one more question. And they were just asking for whom should we be recommending an echocardiogram post-COVID infection? Are they ever indicated if people are asymptomatic?
We're not recommending them. Yeah. I don't know if anyone else wants to comment, but we're not, if someone is asymptomatic or has no symptoms, is not ill, we're not recommending echoes. I think, again, there's the data that has come out a little bit about athletes, and athletes tend to get interventions and imaging maybe when the rest of us don't. But again, I think we have to wait and see if there are guidelines that come out, but we're not aware of anything. We're not recommending routine screening unless there's a concern of symptoms.
Thank you so much, Dr. Moffat. Before I jump into any of the announcements that we have and the brief poll that we have after today's session, Dr. Hodder, I wanted to see if there are any final comments that you wanted to make.
No, I just want to thank Dr. Gupta for a terrific, comprehensive presentation. That was great, particularly for somebody that doesn't know much about kids. It was really, really good. And also special thanks to Drs. Moffat, Weiss, and, as always, Costello for their comments. So thank you.
Absolutely.
I will make one comment about the echoes, that there was a recommendation by the American College of Cardiology, American Heart Association, American College of Radiology, saying that if people are asymptomatic post-COVID, that they do not need to have imaging done. So that's not just our opinion, but that's the opinion of these other heart and radiology societies.
Thank you so much for sharing that, Dr. Weiss.
I just wanted to chime in and say thanks to Dr. Hodder, who's always wearing multiple hats and keeping these sessions going, and then Mitra and Jay. I think that was great, the PEDS ID team. So thank you all for this work. I think that it's we're still learning more as the pandemic goes on, as we're coming up onto pretty much a year, I think, of that we've been having the pandemic. So just appreciate everyone's hard work and great session. Thanks again.
The only thing I would like just to also say that Dr. Hodder, where you're sitting, there's a halo above your head, and I think you should always sit in that same spot because it's perfectly appropriate. I like it.
No, it's the nearest I'll get to heaven. I can't get up my hill. It's still all ice. I don't know when I'm going to get back to the office.
I noticed that too, Dr. Weiss, and I second that. It is very appropriate having the halo above you, Dr. Hodder. And I'm always so humbled to be part of such a wonderful group, and I truly appreciate each and every one of you. So thank you for taking the time to be here. Thank you, Dr. Gupta, for that excellent case and didactic. We really appreciate your time. Just one announcement, our next session will be on February 18th, and Dr. Rebecca Reese will be presenting on the new variants. So keep an eye out for that reminder. I'm gonna launch the poll, right? Actually, it looks like it is inactive right now. So we'll just do the poll next time. Sorry about that, guys. We'll see you guys next time. Thank you.